Thank you.
Thank you.
Chairman Stark, Ranking Member Herger, and members of the subcommittee. Appreciate the opportunity to discuss the CMS rule governing the meaningful use of electronic health record technology and the payment incentives created by the Recovery Act. The widespread adoption of an integrated electronic health records by providers has the potential to improve the health delivery system while reducing waste. Additionally, certified EHR technology used in a meaningful way is one piece of a broader HIT infrastructure needed to reform our nation's healthcare system. As David mentioned, we've been coordinating and collaborating closely with the Office of National Coordinator to ensure that both the CMS rule and the ONC rules set the foundation for the incentive program. As he mentioned, the final rules were released by CMS and ONC a week ago today, July 13, 2010, marking the completion of the first step in a process to expand the use of HIT technology and, more importantly, improve the quality and safety of care for our Medicare and Medicaid beneficiaries. On January 13th, we published a proposed rule that defined meaningful use and described the eligibility and payment methodologies for the program. The NPRM was developed through a close cooperation between CMS and ONC and allowed for extensive stakeholder input and recommendations from several federal advisory committees, and specifically the HIT Policy Committee. After the comment period was over, we received over 2,000 comments from interested stakeholders, healthcare providers, associations, patients, and others. We carefully reviewed and considered all submitted comments and took them into account in making the policy decisions for the final rules. As we worked through the comments, we sought to be as inclusive and as flexible as possible within the bounds of the statute, recognizing the wide diversity and variety of commenters who did respond, including the small and rural health providers and others who may not have the infrastructure in place as some of the larger organizations did. We continue to work closely with the ONC and received additional recommendations from the HIT Policy Committee. It's important to note that this program provides program incentives for both Medicare and Medicaid. Although the programs have different statutory requirements, we've tried to harmonize the meaningful use requirements as closely as possible. For the purpose of this testimony, I'll focus on the Medicare program, but there is a discussion of the Medicaid program in my written testimony for the record. So let me just focus quickly on several areas of the new rule. Eligible professionals, one of the major changes between the NPRM and the final was the definition of eligible professionals was expanded to include eligibility of hospital-based physicians who work primarily in outpatient departments. This was made possible by a change in the original statutory language made in the Continuing Education Extension Act of 2010. Eligible hospitals, there's been consistent and substantial interest in our eligibility policies for hospitals. In particular, we received many public comments requesting that CMS recognize each campus of multi-campus hospitals for the incentive payment. CMS understands the issue as importance to members of Congress, the hospitals, and the public. However, from the agency's perspective, we believe it is important to treat hospitals consistently, and the decision to deviate from long-standing hospital policy in this particular instance without clear statutory direction to do so could have made CMS vulnerable to legal challenges asserting our policies being implemented in an arbitrary manner. We intend to remain consistent with other payment policies and make incentive payments based upon how hospitals have organized themselves under provider numbers. There's a more detailed testimony of this issue in my written testimony. In meaningful use, we made a number of changes in the final rule to take into account the numerous comments we received. We tried to provide flexibility and to make some changes that would better accommodate eligible professionals in hospitals for the Stage 1 requirements, which will be for the 2011-2012 years. Some examples is we changed the all or nothing approach to the objectives to a required set and a menu or optional set. But we do still allow the eligible professionals are still required to meet 20 out of 25 objectives, in the hospitals 19 out of 24. Where appropriate, we change thresholds to reduce and final response to comments. We removed administrative transactions in this stage, although they will be put in next stage. We had some concern about states' ability to meet the requirements to implement them, and we have decided to allow states to have some flexibility, but limit it to 4 public health measures. We also included computerized physician order entry. However, we responded to concerns and comments by reducing the objective to 30% of medication orders. We also provided patient-specific education resources and advanced directives added to the final rule in response to comments and HIT policy recommendations. For clinical quality measures, Congress recognized the importance of reporting clinical quality measures in the high-tech legislation. CMS supports this requirement but recognizes the infrastructure is not yet available. In response to comments, we limited CQMs to only those who have electronic specifications. Eligible providers will now be required to report on 3 core measures and another 3 from a set of 41 measures. Hospitals will be required to report on 15 measures as applicable to their patient population. So finally, in conclusion, the administration has made the adoption and meaningful use of EHR technology a high priority. The final rule lays the groundwork for establishing a robust national health infrastructure that supports the adoption of EHRs that can help make providers' practice safer and more productive. We look forward to working with Congress and our many stakeholder partners as we implement this rule and future rules to advance the use of HIT in our healthcare system. Thank you very much, and I'm happy to answer any questions that you might have.